Good evening to the people of Savannah. Thank you very much for coming out here tonight. So this is an MS Views and News Compass to MS Care program. All right, and we do these programs around the country. We do this series, Compass to MS Care, every single month in one location or another, usually in rural America, as well as underserved communities. We've been to some very, very remote areas around the country where internet is not even accessible. So getting the word out and being live streaming during those programs makes it a little bit more challenging. For those that don't know me, my name is Stuart Schlossman. I too have multiple sclerosis. That's another story altogether. But tonight we're here, and I want to tell you that we are supported by Banner Life Sciences, Genentech, Bristol Myers Squibb, and TG Therapeutics. And if you don't know those names, maybe you know better the names of the medications. So Banner Life Sciences is Beferitum, and Genentech has Ocrevus, and Bristol Myers Squibb has Zeposia, and TG Therapeutics has the newest medication that's out there called Briumvi, and I'm sure you'll be hearing about that as well. We also have exhibitors tonight. We have Alexion, Beferitum, which is Banner. We have Bristol Myers Squibb. We have the National Multiple Sclerosis Society is here exhibiting today. We have Genentech, and we have TG Therapeutics. All right, so tonight's program, Dr. Hemphill will be speaking with you all about treatment options, fatigue, spasticity, pain management, all right, access to care in rural America and the underserved communities. All right, and he's got a lot to speak about. He'll be speaking for about 40 minutes, and then we will do Q&A. In the meantime, let's welcome Dr. Hemphill. Come on up. Thank you.
Good evening, everyone here in person and those tuning in virtually. As Stuart said, my name is Michael Hemphill. I'm a neurologist here in Savannah. I do probably most of the MS work in this part of the country and in southeast Georgia. And as you know, there's a great need. And so we're very happy in our practice to be able to serve people with MS. And I always enjoy getting out and educating folks about MS. I think there are plenty of things that you want to talk about that you don't have time for in your physician's office, in your provider's office. And so this is the opportunity to hopefully hear about some of the things you would like to talk about in that setting, and also ask some of the questions you don't get a chance to ask about. So actually, I'm really going to talk about an overview of MS, and then we can drill down on it in the Q&A. But I just want to make sure everybody's on the same page about understanding what MS is, how we diagnose it, a little bit about what it is biologically, the tools that we use for diagnosis, especially MRI scan and lumbar punctures, and then how we treat it and the principles of treatment, because that's changing. It's changing fast. And then symptom management. I know a lot of you came here to talk about specific symptoms. Dr. Samos just gave a great presentation on neurogenic bladder, which we see with MS, and I'll try to talk on some of the other manifestations of MS that require treatment as well. So to start, I always like to think about MS as, and talking with folks about it being really about three words. And those three words to remember are autoimmune, myelin, and central nervous system. If you kind of understand what those three words mean, you've got a pretty good grasp of what's going on with MS. Autoimmune means your body's own immune system has turned against at least a part of yourself, some of your own tissues. And in this case, it's turned against your myelin tissue. Now, myelin is essentially the insulation material around nerve cells. So you see it in the cartoon here. You see a healthy nerve there on the left part of the right-sided cartoon. And on the right side, you see what happens whenever the body's immune system has attacked myelin, and it's denuded. It's called scarring, and we're going to talk more about this scarring that goes on. These are what we call lesions. Now, you hear lesions talked about a lot, and you may never know what we're talking about, especially when we're talking about MRI scans, but a lesion literally just means an area of injury or an area of damage. And so what you see here on the right is a portrayal of a lesion after the immune system has attacked the myelin. And so that electrical just like with the insulation around an electrical wire, the conduction across the area where the insulation material is gone, where there's a short in the system, it just doesn't work very well. The electrical current bleeds out, and so the lights don't come on. And the same thing happens in the nervous system. If you're lacking myelin, then the nerve may not be conducting efficiently and as fast as it ought to, and that leads to a breakdown in function in whatever part of the brain or spinal cord or other part of the nervous system where the nerve may be traversing to and fro, carrying impulses. Now, in the case of MS, the area of the nervous system involved is the central nervous system. That's to be distinguished from the peripheral nerve system. Sometimes you've heard me, many of you heard me use the analogy of the I-95 and the exits. So the brain and spinal cord is sort of analogous to, say, leaving Washington, D.C. and coming down I-95 to Savannah. And that is really the central nervous system. Where you get off at an exit is the peripheral nervous system. And they really immunologically are different. So the myelin in the brain and the spinal cord are in Washington and I-95 is different than the myelin in the exits. And so the immune system attacks only the central nervous system myelin in MS. It does not attack the peripheral nervous system myelin. So that even though you feel like you have numbness and tingling in your hands and feet, it's not the physical nerves going to your hands and feet that are the problem. It's actually where those nerves connect to in the spinal cord and going up and down that interstate, up and down and into the brain is where the problem is. And then the optic nerve is actually not part of the peripheral nervous system. It's an extension of the brain. Literally, it's an outpouching of the brain. So that explains why the optic nerve may be affected. So that's really sort of a basic understanding of what's happening with MS. We're going to drill down a little bit more on that in talking about inflammation with MS and neurodegeneration, because that's become more important in our understanding of MS and the treatment for MS, and why we believe that we need to treat early and continue treating for a long period of time. There's a lot more that we can discuss about what MS is and the pathology of it. I will just say that historically, we've known a lot of this for over 100 years. Pathologically, MS was first really described by neurologists in Europe and specifically in Paris in the 1880s. And they described, basically in French, multiple sclerosis. Sclérotique is a French word that means hard. And so these lesions that we talked about form little hard plaques. So you'll hear about the lesions of MS, the areas of damage, sometimes referred to as plaques. And literally, if somebody with MS dies and we examine the brain, you can actually feel these plaques, and they look a little different, but you can feel them between your fingers, and that's where the sclerosis part of multiple sclerosis came from. And I'll talk in just a minute about where the multiple part came from. So the people who get MS is still a mystery. So we can't really predict who's going to have MS. We know it affects people in the younger years of their lives. Now, it's not very common in children, but it probably does start in teenage years, because when we diagnose it is often in the 20s, and the way we diagnose it is we see these lesions in the MRI, on the MRI scan now, and we know they have to have been there for some time. They didn't just appear at the time that somebody came in with symptoms. So we have to assume that the process begins when that person was 5 or 10 years younger. So it happens in young adults. It's been known as a disease of young adults. But we also can see patients later on in middle age, and so it's not uncommon to make a diagnosis of MS in someone over 50. and that person has just fortunately not had any lesions, any involvement of the spinal cord, and so they don't have any problems with their mobility. And then, but when we see them, they may have other problems that they present with, and we do an MRI scan and we can see that there has been MS there for quite some time. So even though the typical age is, say, between 20 and 40, 20 and 50, we certainly see teenagers with it, and we see people over 50. And so it does span a long period of time. Likewise, although it's known for being more common in women, we certainly see it in men. Sometimes it's even worse in men. But it's about 3 times more common in women than it is in men. There was a study done by a famous epidemiologist at the National Institute of Health, John Kurtzky, 50 years ago, showing that the further you grew up before age 15, the further you were from the equator, the higher the risk was of your MS. And so people in the northern tier of the U.S., in Canada, and in northern Europe have typically been diagnosed with MS than people who live in closer to the equator. And that seems to be true in the southern hemisphere as well. That concept is actually changing. I know when I first came to Savannah about 100 years ago, I gave a talk to the people at Memorial, at the Grand Rounds, about MS, and they kind of looked at me with a blank expression, and one old doctor kid stood up and said, "Son, you're just not going to see that around here. There's no use talking about it." And so I just kind of shrugged my shoulders. I just talked about this whole issue. So I knew that it was going to be infrequent, but probably more common than he thought. Subsequently, we've seen that, in fact, it's a whole lot more common than we thought it was. And so, again, this idea of it being just in people who have grown up in northern latitudes has not held up terribly well in places like Savannah, I think, are proof positive of that. We have an increasing awareness of MS severity, especially in African Americans, and especially in male African Americans. Dr. Mitzi Williams, who was at MCG, now practices outside of Atlanta, is an African American neurologist, specialist in MS, who is doing a lot of work now, research, and trying to see if she can identify some factors that may be responsible for that. People talk about infections and whether that may be a risk factor for MS, and it may well be. We've looked at virtually all the viruses that we know. The only one that really has kind of popped up is the Epstein-Barr virus, the EB virus, and that's the virus that causes infectious mononucleosis. And everybody who has MS has been exposed to the EB virus, has antibodies to the EB virus. The problem is that 80% of the rest of the population also has antibodies to MS. So it's not very specific. So you can't really discriminate on who is at risk for MS based on whether or not they've been exposed to the Epstein-Barr virus, whether they have antibodies to it or not. So we're still looking. And then people also ask about whether or not, if they have it, whether their child is going to be at risk for it, and that's certainly an understandable concern. Turns out not really. We do see it occasionally. We will see a parent and child occasionally, but the risk has been said to be around 2 or 3%. And we do see it in identical twins, but again, less so than what you would think if it was a purely genetic problem. So there may be some genetic predisposition. There is a lot of work still being done on that. But right now, we certainly can't say that if you have MS, there's a significant risk for your child and that they need to be screened or monitored for MS. What are the symptoms of MS? Well, they're legion. You can see on the left that virtually every part of the central nervous system is involved. On the right-hand side, you see some of the more common symptoms, especially those that we see with relapses. By far the most common symptom we see, I think, at the outset is numbness and tingling. And that's kind of tough because numbness and tingling is kind of a nonspecific symptom that we see in neurology an awful lot. And it can be everything from a carpal tunnel syndrome to a diabetic neuropathy, and lots of other things. And so we have to kind of screen people a lot of the time who come in with numbness and tingling and determine whether this could be MS or not. So it's a very common symptom, and that's always due to involvement of the spinal cord. So if we do see numbness and tingling, we need to be sure we look at the spinal cord as well as looking at the brain to see if someone has MS involvement there. Likewise, gait unsteadiness is a very common presenting symptom of MS, or a symptom that somebody may have with a relapse. That's also due to a sensory problem. Essentially, your feet can't tell your brain fast enough where they are in space, and so people stumble. And that also is involvement of the spinal cord. And MS has sort of been known historically as a problem with mobility. And a lot of that is actually not paralysis, it's this problem with sensation in the legs and the ability to transmit that successfully and quickly to the brain. Another common problem has been vision problems, usually in one eye. That's called optic neuritis. That's an inflammation of the optic nerve. And people who have that have pain when they look from one side to the other with that eye. And they may have some blurring of their vision. Sometimes if they wear contact lenses, they think they've just got a dirty contact lens. Or if they wear glasses, they just keep repeatedly cleaning their lens, thinking that that's what it is. But in fact, it's optic neuritis. People don't lose their vision in optic neuritis with MS. They just get blurring of their vision. We do treat it, but even if you don't treat it, it gets better on its own. It may not be completely better, or people may still be able to see pretty well, but don't really see colors as brightly in that eye, but they do get improvement in their vision. The other things that you see listed here are not as common with presentation of MS, but they may become important as people with MS go on in the next decade with MS or 2 or 3 decades later. And those are problems with fatigue, mood, and cognition, memory. And now we're really looking more and more at these issues in people with MS, and as we'll talk about later, it's one of the major things we are looking at when people come in for visits and when we're looking at MRI scans and what we're considering with their therapies. Other phenomena that you may hear about are these listed below. Lhermitte's sign, named after a French professor, Lhermitte, described this back around the turn of the 20th century. And those consist of paresthesias, and paresthesias is really just a medical word for numbness and tingling. So it's a sort of a creepy, crawly feeling or tingly feeling that people get, whether it's occurring in a limb, or in this case, it occurs in the neck. And when it's also called the barber chair sign. So if somebody's flexing their neck, their chin down on their chest, they feel an electric shock, or they feel tingling going down their neck. It may go down their back, or it may just radiate out into the shoulders or the arms. It can be varied, but it's associated with MS, but it also can occur with other problems in the spinal cord, but it's most notable for its association with MS. The Uthoff phenomenon is something you've probably never heard of, but it's very important for patients and physicians alike to know about. Again, named after the professor, an ophthalmologist who described it. It originally was described with vision, and it was found that Uthoff found that people who are exercising and had optic neuritis previously often would get blurring of their vision again. Now, they weren't getting optic neuritis all over again. They were just experiencing this phenomenon that would be temporary. It wouldn't last any more than a few hours, up to 24 hours at most. And it went away if the person stopped exercising. Or, and what was found later, it really wasn't the exercises, it was getting overheated. So we see a lot of this in Savannah in the summer. People go out and working in their yard and get exposed to the temperatures that we have here, and they will feel the numbness and tingling that they may have experienced initially with their MS. They experience blurring of their vision, like they had with their optic neuritis. They may have increased fatigue. And so that's why you see people with cooling vests a lot of the times. They're trying to cool their core temperature, and that's not for prevention of an MS attack, it's for prevention of Uth's phenomenon, or what, well, more commonly we call a pseudo-relapse. People call thinking they've had a flare-up or exacerbation or relapse, when really what they're experiencing is this phenomenon where they've got not only overheated, but they're fatigued, they didn't sleep well, they don't feel well, even with women with menstrual periods. Some kind of physiologic stress has brought back the symptoms that they were experiencing with their MS sometime before when they had an attack. And so they're continuing to have the same symptom whenever they are stressed like this. So it's very important to understand what this is, because it's one of the reasons when people call in and say, I've got these symptoms again, I need some steroids, we may say, no, you really don't need steroids, you just need to get some rest, stay out of the hot weather, whatnot, make sure you don't have an infection or something like that. That's the problem, and not the fact that you have an attack of MS. One of the other ways that you might experience this is taking a hot bath. Just a historical note again, I do remember the days when before MRI scan, that's how we diagnosed MS, or part of how we diagnosed MS. We would put people in the hot tub in the physical therapy department and run their temperature up, and if the vision got blurred in one eye again, or their numbness and tingling came back, we'd say, oh, you probably have MS. And so that was high-tech diagnosis of MS at the Johns Hopkins Hospital back in the 1960s and 70s. I am happy to say that we have moved beyond that. But as someone who knew MS before MRI scans, that's why I think MRI scans are still a miracle of modern technology, because we're not having to put people in hot baths again. So the diagnosis of MS is, as I mentioned, occurs when we're able to determine that there are lesions within the central nervous system, and specifically whether there are lesions in the central nervous system that are spread over space and over time. That's sort of the cardinal criteria for making the diagnosis of MS. So it can't just be one spot in one place at one period of time. We need to be able to distribute, tell one way or the other to determine whether or not it's involving one area of the nervous system and then another area of the nervous system over at least 2 points in time and more. And that's what I mentioned earlier. I'd come back and say what the multiple was in multiple sclerosis, and that's what the multiple is. Multiple is that there's involvement of different places in the nervous system, such as the optic nerve and the spinal cord, or the back part of the brain in the spinal cord, and have occurred on more than one occasion. Now, this is determined not only by seeing where people's symptoms are, but also looking at the MRI scan and seeing where these lesions are. But sometimes looking with the MRI scan, you can't really tell when they occurred. And that's where the cerebrospinal fluid comes in handy, and we'll talk about that in just a few minutes. But MRI has now become the mainstay not only of diagnosing MS, but also being able to determine its course and to manage it. At the time of diagnosis, you see these typical lesions, these areas of injury that occur in the brain and the spinal cord. At the time of relapses, we're going to see in a few minutes, in the inflammation, how we can tell there's active inflammation going on at the time, and there's actually disease activity. And then the progression we see with the scars that form for that. This is an example of an enhancing lesion, which is the inflammation that occurs. These are the lesions we call T2 lesions, which are the white areas. And they're called T2 because that's the sequence on MRI they occur in. The T1 lesions are where there's so many T2 lesions in one place that actually you lose tissue and fluid accumulates. And then more and more we're looking at the size of the brain and the gray matter structures of the brain to determine if there's any shrinkage. And this is what the lesions look like in the spinal cord, these T2 lesions. The lumbar puncture, yes, we still use the lumbar puncture, but it's not what it used to be. It can usually be done by a radiologist under X-ray visualization, and so it's not as uncomfortable or as difficult as it used to be. It does provide important confirmatory evidence of dissemination in space and time that we talked about earlier by showing these oligoclonal bands. So you'll hear that term batted around, that we want to know what the bands were, or if there were bands in the CSF, and that's what we're referring to. Those are unique bands within the spinal fluid. We also are doing other tests now to exclude other diseases that can look like MS. Most importantly, something called NMOSD, neuromyelitis optica spectrum disorder. It's a mouthful, or just NMO, we usually refer to it as. It's important because it's treated differently. It has specific treatment than MS. And then something called MOG antibody disease, which can be seen a lot in children, but also can occur in adults and require specific treatment as well. The goals of treatment in MS, of course, are to prevent the relapses. And I mentioned the pseudo-relapses, but also to prevent disease progression, that is, worsening of gait, dexterity, bladder function that you heard about, and as I said, cognition and mood. The goals of therapy are to try to shut down MS and to prevent the relapses and prevent the progression. The way we do that is importantly by starting treatment early. We don't want to wait. The one thing we know in 2023 is you don't want to just wait and see. You want to treat it as soon as you identify it, and you can see on the right here sort of the outcomes that occur with early treatment versus late treatment. People do worse and have worse outcomes if they wait. The treatment that we use are based on the effectiveness of the treatment, which is largely determined in clinical trials. Those are the same trials that the FDA uses for determining approval for a medication. The side effect profile, I'd usually like to break into two categories of safety and tolerability. Safety is, can it hurt you? Tolerability is, it going to bother you? But there are two distinct things that you need to think about in determining whether a drug is right for you. And then the route of administration and the frequency of administration, and those are often patient preference. So we put all these together to come up with to customize the right treatment for every patient. Once we decide on the treatment, we monitor for new disease activity, and we also do blood tests to look for any safety issues. The MS disease modifying treatments that we use have really come a long way. We started in, again, I remember all of this, so I have all the history in my head here from living this. I knew Lermite way back when, but no, in the 1990s, we had the advent of the interferons. In 1992 was beta-seron. There actually was a lottery for it at that time. There was such demand for it that they couldn't make enough of it initially, and people had to take a number, and it took about a year really to be able to satisfy that demand, where people no longer had to take a number to get it. All of those drugs during the 1990s were delivered by injection, and so MS treatment was sort of famous by the discomfort of the therapy that people had to take. In the 2000s, a drug called Tysabri came out, was given intravenously once a month, and that's still available. In the teens, the advent of the oral medications around 2011, 2012, really three different categories. The first drug was Aubagio and Gilenya and Tecfidera, so you probably know those names. And then there now are drugs that have come in to follow up on those, and there are new iterations of those, either have increased effectiveness or more commonly are more tolerable. And I will add to Vumerity there, our friends who make Bafirtam, who also is in the same category of medication as Tecfidera and Vumerity. the fumarates. And then most recently in the late teens, now and as recently as 2023, we have new drugs that attack B cells. And initially that was Ocrevus, given intravenously every 6 months, and then Kesimpta, which is given subcutaneously every month. And now, as Stuart mentioned, the most recent drug that we have available called Briumvi, which also is given by vein every 6 months. And then Mavenclad is an oral drug developed really probably 15 years ago, but then came out in the late teens and is also available and by a different mechanism of action by all the others. So these are the disease-modifying therapies, and I'm happy to talk about any one of them, particularly if you have questions. I want to be sure I finish up here. The last thing I want to mention is symptom management. As promised, fatigue is a big problem for most people with MS. The first thing that we do is make sure there's not some treatable cause specifically. Sleep apnea is a very common cause, and so we want to make sure if somebody snores at night that we evaluate that, because that can be treated. If somebody has a depressed mood, they feel they have low energy, we want to make sure that's treated. If we've been able to exclude those things, then we use stimulant drugs, either the same drugs we use for narcolepsy to keep people awake, called Nuvigil or Provigil or modafinil and armodafinil, or the generic drugs, or stimulants like we give kids with attention deficit disorder, Ritalin and Adderall. Mood and anxiety, there are plenty of drugs for those. We want to make sure those are treated. There does appear to be an increased risk of these symptoms in people with MS, especially later on. And then if they are not well controlled with medications we might use, we try to refer for psychiatry evaluation. Cognition, as I mentioned, is increasingly important, especially as people get older. And cognitive rehab is available to help people adapt and learn kind of tricks that they can use to help despite having some memory loss. Spasticity, somebody referred to the tightness in muscles. There are oral medications like baclofen and tizanidine that are available. We do botulinum toxin injections in the extremities when the muscles get too tight, and then physical therapy is a mainstay. For dexterity, that's usually occupational therapy. If people are having trouble with coordination of their fingers, it's the occupational therapists who deal with those kinds of fine motor functions. And then mobility, those folks are treated by the physical therapists. We get durable medical equipment aids if people need canes or walkers to help maintain their mobility, or wheelchairs. Ampera is a drug that we've used. About 30% of patients who have mobility problems will respond to MS and to Ampera. And then with bladder function, you've heard Dr. Samowitz's recommendations about that. So I think there'll be some more questions about this sort of thing, and I'm happy to answer those, but I want to make sure we finish on time and allow enough time for that.
So thank you, Dr. Hemphill, very much. What do you all think? All right, so before I go around, first off, anybody in the audience have questions? Great. I'm going to be back there in a minute. I'll get to all of you in a minute. One that's online that's, they want to know how it is that you determine which is the drug to use for them. They're newly diagnosed.
Newly diagnosed. Well, it's the first thing we want to know is really how extensive is the involvement, and we do that by the clinical, so the symptoms that people present with. The MRI scan is very important for that. Is it just involved the brain, or is it involved the brain and then the spinal cord? Where exactly is it, and how widespread, and basically the severity. And then we try to pair that with the effectiveness. So I mentioned that earlier that we look at efficacy, determined often from the clinical trials, is how strong the medicine is. And so if somebody has widespread involvement of their MS at the outset, we want to pair that with the highest potency drug that we have. And then we go look at safety and tolerability to make sure that the patient is comfortable, that someone's comfortable with those. And then after that, we look at convenience, personal preference in terms of route of administration, the timing, how frequently it's given.
Thank you. Question from the back of the room.
Yes, sir. You said that MS can be in the body earlier, but you don't find it till later. Like my daughter, she had it. She didn't get it till later, but she had so many MRIs. Why weren't they able to detect it through those MRI? Is it a separate? It's a different MRI that you guys check for MS from other MRIs?
Well, I can't answer your specific question, obviously, in your situation, but no, they're not different MRIs. Now, there are different sequences that are done, and there may be different expertise or interest in MS by the radiologist who's reading them and how often they see MS. But I think by and large, we would have a good chance of seeing MS with sequential MRIs. But individual circumstances different. It's hard to know without knowing the details what happened in that specific case.
So they only show up on the brain, or so is they only show up on the brain or on the spine or both?
It can show up in both. I'd say most commonly it's in the brain. So that's going to be the best place to look, because you may have lesions there that somebody's unaware, they don't have any symptoms from, because the brain is so redundant, there's such capacity there that you can have multiple lesions in the brain and basically nobody can tell you have MS. On the other hand, in the spinal cord, it's not very big around. So if you have lesions in the spinal cord, you're probably going to know it. You're going to have symptoms. You're going to have numbness and tingling. You may have gait unsteadiness. You may have weakness. So usually if there's something in the spinal cord, you're aware of it, or the physician can detect it. And we can see it on the MRI, but it's not as if we're going to be surprised usually that it's there.
Is numbness and tingling sometimes always it's related to diabetes? Is that the same type of numbness and tingling?
It's the same feeling.
Thank you. All right, question online. So you spoke about the symptom management. This person wants to know what you could tell them about. They have fits of crying, they have fits of laughing, and they've heard about what it is from their doctor, but they want to hear it from you as well.
So those symptoms are called pseudobulbar affect, or PBA. And that's where someone may spontaneously laugh or cry sort of inappropriately, or certainly disproportionate to the stimulus. And they'll actually say, I don't know why I'm crying because I don't feel sad. Or, yes, I was laughing, but it wasn't that funny. And they may laugh in inappropriate situations, in a funeral service or something like that, or in church or something where they shouldn't, where they don't want to. So that's called pseudobulbar affect. We've known it about a long time, but we couldn't do much about it. We would always want to make sure somebody wasn't depressed, for example, but there now is specific medication out there to use for this. And so we do try to have a pretty low threshold for picking that up and making sure it's treated.
Well, my comment, then a question. One, either I owe you some money or you owe me some money, because I used your speech yesterday, but you used some of my pictures on your slideshow. So I'm kind of like, but my question is, which one, I guess, do you consider most drastic, the ones on the spine or in the brain, and how does that affect the bladder? Because I have lesions on both, but I'm kind of now like, well, which one is affecting the bladder the most, and which one should we focus on?
If there are bladder symptoms attributable to or due to MS, it's because there are lesions in the spinal cord. As Dr. Samwood said, there can be plenty of other reasons to have bladder symptoms, due to the prostate or other things like that. But if it is due to MS, it's because of MS involvement of the spinal cord.
I have a question about the cognitive rehab. To me, I'm thinking, word games and stuff like that, but is it more complex? Is that like a prescription, like physical therapy, or does it get that intense?
There is that kind of therapy available in places. I don't know that we specifically have anyone here doing it that much, but there are neuropsychologists who can work with that. Sometimes the speech therapists do that. But you're right. It is developing some modalities by which you both can kind of stimulate your cognitive function, but also workarounds. So from things as simple as if your memory's an issue, trying to develop the tricks like memory savants can kind of use, try to remember a picture with each word or something to help you with your memory, realizing that your memory is not as good as it was. That's not where it should be. We want to be a lot further on. The thing we know about cognitive function now is that the best way to treat is to prevent it. The best way to prevent it is to treat early and as aggressively as possible. Because once it's happened, it's tough. We don't have specific treatments for it, and we're really just trying to help people along by developing these techniques, these adaptive techniques.
A lot of people seem to have, with MS, seem to have problems swallowing, or they get food stuck in their throat and they're choking. And what do you have to say about that?
That's actually a pretty unusual symptom with MS. And so if somebody has that, I would say the first thing to do is to be sure you've excluded other causes. So I would not, and this is true in general, there is a problem that can happen with MS. One of my old professors used to say the fastest way to non-thinking is a diagnosis of MS, because we want to attribute everything that happens to the MS. But other things happen too, just like they happen to other folks. So I think swallowing is one of those things where there are other reasons why people may have swallowing issues, from gastroesophageal reflux to problems, anatomical problems in the pharynx. And so I would say look first for other things before you attribute it to the MS. There is no specific treatment from MS. If it is there, it's due to involvement of the brain stem, the centers where the swallowing reflexes are located.
Okay, next from here.
If my symptoms are mainly from lesions in the spinal cord, why am I getting only brain MRIs every year instead of spine MRIs every year?
Well, again, I don't want to address particular treatments by physicians, but I can tell you one possible reason would be if your treatment team already knows that you have involvement in the spinal cord and you have these symptoms. You don't have to necessarily repeat the cervical MRI every year, because, as I said before, the spinal cord is so dense that if you have a new lesion, you're going to know it. You're going to have new symptoms. Whereas the brain is different. It's got such capacity that you can have new lesions and not know it. And the only way we know it is by getting the MRI scan.
All right, next question. Is macular degeneration associated with multiple sclerosis?
No, not to my knowledge.
Okay, and do you know why fingolimod is not covered by insurance?
No. I draw the line at insurance. That's
Okay.
I have a learning disability for insurance.
Okay. And the next question pertains to spasticity. If people don't do well with Botox and they're not doing that great with baclofen, what's the next step?
Well, one next step is consideration of a baclofen pump. So there's a limit to how much baclofen we can give by mouth because it's distributed everywhere, including the brain, and it may make people sleepy or drowsy. And so that's a ceiling for the dose that you might be able to use. That may not be enough for the spasticity. So an alternative is delivering it directly into the spinal canal, and that involves surgically placing a pump in the abdomen under the skin with a catheter that goes into the spinal canal and dripping the baclofen in directly into the spinal fluid. And so that gets more baclofen to where it's needed in the spinal canal without affecting the brain and causing dizziness, drowsiness, sleepiness.
Thank you for that. What's the difference of Lyrica and gabapentin or Neurontin?
Those are in the same class called gabapentinoids. Gabapentin is older. It was developed in the 1990s as a seizure drug before it was found to be really helpful for pain. Lyrica is pregabalin, and it's FDA approved for not only neuropathic pain that someone with MS might experience, but also for seizures. And so they're both in the same class, they're just a little bit different. And so sometimes people will have some side effects with one and not the other. There's difference in dosing, but these are all fairly subtle.
Is there a MS screening that you can request through your primary care?
Well, the only screening really is, if somebody suspects it, it's an MRI, but if somebody's not having symptoms, that's not probably a very effective technique. So only if you're having symptoms that the physician or you suspect it could be MS.
Okay, the next one wants to know, which MS medication do you recommend more than others? I'm going to put you on the spot with everybody in the back, right?
Yeah, right, exactly. Well, as we said earlier, I mean, the wonderful thing about having so many new treatments out there for MS is that we can customize it. So every patient's different, and so I wouldn't say there's one best medicine for everybody, because everybody's different. And so I think the best medicine is the best medicine, the medicine that's right for you, and that's a combination of how much of a potent medicine or a highly effective medicine you need, the safety and tolerability profile, and the convenience and personal preference and comfort of giving it. So I wouldn't want to say that one size fits all.
All right, thanks. Next one. Concerning Dawson's fingers on the MRI, is it always associated with MS, or is there something else that it can be associated with?
Well, it's pretty characteristic. So these are T2 lesions. So that is, they're the scars or areas of injury seen on the T2 sequence of the MRI. And that's the MRI is not an X-ray, it's a magnetic field. So it's the way the magnetic field's adjusted to get the images. And on the T2 sequence, we see that array. In fact, what you were seeing on the MRI earlier were Dawson's fingers. They're spread out like fingers when you look at the brain from the side. You can't really see it if you cut it this way or this way, but if you slice it this way, you see these fingers that look like that. And they're perpendicular to the lakes inside the brain called ventricles, lateral ventricles. So they have a characteristic appearance, and we know them as Dawson's fingers. That's sort of a shorthand.
Great, thank you. What is the life expectancy for somebody with MS? Don't ask me, because I'll tell you forever. But, and also, person's asking, does anybody ever die of complications?
I would say that, especially in this era, people die with MS more than they die of MS. Now, I have to say, people who developed MS in the years before we had treatments or good treatments may have more disability in later stages of life, and specifically may be more prone to urinary tract infections that may spread to the bloodstream, or they're immobile and may be confined to bed or wheelchair and developed what he referred to earlier, decubitus ulcers, which are pressure areas from just lying in one place, and the skin breaks down and can get infected. And so lots of complications can develop, but those really are for people who are most severely affected with MS. And fortunately now our mission is to try to treat people early with good enough medication that we're not going to see that.
Thank you. Let's go back to the COVID era. What do you do for people with MS that are suffering from long COVID and extreme fatigue?
Well, we have to treat them the same way that we treat fatigue in general. I mean, long COVID's still a puzzle for everybody. Nobody I know has a specific treatment for long COVID. So we end up kind of like I talked about before with fatigue. We look for treatable causes, especially sleep disorders and depression. And then if we need to, we use the stimulants. And so people have brain fog, for example. We may end up using Adderall or Ritalin or a medication like that. We're not any better than that right now.
Okay, here's the question to be. How do you keep from getting worse with MS?
Very good. But that's the mission for all of us. And the way we believe that you keep from getting worse with MS is to get effective treatment. And that means getting good care with good medication, with appropriate monitoring, and with both of the MRI scans and laboratory studies when needed, and regular visits, and for everybody to take their medication. Nowadays, our treatments are so good. If I see someone with a relapse of MS, I pretty well bet that they've stopped taking their medication.
What MS disease-modifying therapies are recommended for patients with lymphocytopenia?
With lymphopenia or lymphocytopenia. What medications are recommended, you saying, with those? Yeah, a lot of the MS medications actually cause lymphopenia, and so that's the goal of therapy. If somebody has that to start with, we first of all have to know why they have it, and if, for example, if they've got a condition, a medical condition with too few lymphocytes, or they're on some kind of treatment, drug therapy that's depressing the lymphocytes, we need to know about that. But there are drugs that don't depress the lymphocyte count that we might consider, but I think the most important thing is why would somebody have a decreased lymphocyte when they're not on a drug that causes that, and determine that first.
What are your thoughts and recommendations for children and grandchildren of adults with MS?
Well, as I mentioned earlier, the genetic heritability is very low, and so we don't feel that people need periodic MRI scans. It's just doing something and worrying about something that is unlikely to occur. As I've mentioned, it's maybe 1% to 3% or so. So we do not recommend routine screening of children and grandchildren of people with MS.
She said, what? Vitamin D. I just want to ask that again.
The question is what about vitamin D? And vitamin D is, we do recommend vitamin D. It's been shown that vitamin D does not, and when I told you about the northern latitude hypothesis, it was thought, well, it must be vitamin D that's causing the problem. Well, it turned out not to be the case. However, in looking for that, even though we saw that vitamin D deficiency is not a cause for MS, people who had persistent vitamin D deficiency didn't seem to do as well as other people. So we do check vitamin D levels, and we try to keep them up in the high normal range with vitamin D supplementation.
What's your normal range?
It's over 30 and milligrams per liter, and we try to usually keep them up in the 40 to 50 range.
So when you see patients with more symptom burden, maybe like moderate, and no increasing lesions on MRI, do you ever, is it successful to change their disease-modifying treatment, or do you kind of focus on other management of their symptoms?
Yeah, that's a good question. You have to come to grips with that and make a decision. Are the symptoms, just like we talked about with fatigue, or is it due to sleep apnea or some other sleep problem, or is it due to just the MS? And so the first thing is sort of exclude other treatable causes, and then if you don't find those, you do the best you can with the few tools that we have. Unfortunately, our tools are often not that great. But I would look hard to determine if the disease is progressive. And I didn't get a chance to talk about progressive MS, but that's certainly the hot topic right now. And that is, we know that aside from relapses, independent of relapses, MS can gradually get worse on its own. And especially we see that in individuals as they get past middle age and get into their 50s and 60s. And so we do believe that treating early helps to avoid that, but it may well be that we're seeing people progress, and the signs that our MRIs are not so sufficiently sensitive to pick up the fact that it's MS. For example, the one thing we use now is didn't get to talk about is the brain shrinking faster than it should? All of us have shrinking brains. After we're 25, our brains begin to get smaller and smaller. It's just people with untreated MS have shrinking faster and more than other people. So one of the goals of treatment is to prevent that from happening. But the measurements for that and determining that are difficult. We do, and it's important. That's why it's important a lot of times to get your MRIs at a facility that's used to dealing with MS, and not just a general facility that does MRI scans. So an MRI scan is not an MRI scan. An MS MRI scan done in a facility that does them by guidelines that are international guidelines for MS is very important because one of the things that we do there is to make sure we're measuring some of the things we can measure to see if there's a change. And that may be a change over 5 years. You can't just look at last year's scan sometimes. You got to look at 5 years ago or 10 years ago even to see how much of a change there is. So a lot of it is due to the fact that we probably aren't yet able to determine with the software and the magnets that we have in our MRI scans to be as sensitive as we would like in determining whether there's actual progression of the disease causing symptoms. And that's definitely a challenge and something that hopefully will get better every year.
Great, thank you. And now for the next multi-fold question, and that is that somebody is, or people are over 60 or 65, and all of a sudden their disease-modifying therapy is not working for them and they're getting worse. And the next question to combine with that is, what do you do for somebody that's been diagnosed with SPMS at 65, and what kind of medication would you put them on at that point in time?
Well, anyone who's getting worse in their 50s and 60s, by definition, has progressive MS. If they had relapses earlier on, we call it secondary progressive MS or SPMS. I and many, I think probably most people now in the field feel that MS is one disease. It just happens to have relapses and inflammation in the earlier stages, and it causes this progressive neurodegeneration in the later stages. So the way to prevent the progression and worsening in somebody at age 60 is to treat them aggressively at age 30. Now, obviously, we can't do that. We can't go back and change history. But we do try to treat with the most effective drug that we have, and that may be a higher potency drug, but it may become with some risks, and so we again have to balance the safety and tolerability with the need for an effective drug. So we, and I think a lot of us use highly effective drugs rather than backing off at somebody in their 50s and early 60s. We may continue to use highly effective or high potency therapy, hoping to avoid that. They're not really good studies to be able to demonstrate that because it's just difficult to find. You have to do the studies over a long period of time. And so you'll find that MS neurologists probably differ a lot in how they address those situations. But it happens. And again, the main thing is to try to be able to treat early and aggressively.
Okay, for those that have MRI and new lesions are found on the MRI, but their symptoms are not worsening, what do you do then?
That's going to happen in situations where there are lesions on the MRI of the brain, as I mentioned. As I said, you can get lesions there and not have any new symptoms. Whereas in the spinal cord, that's probably not going to happen. But yes, it does happen in the MRI of the brain. And so if we do see new lesions in the brain, we start thinking about looking again at the therapy somebody's on to determine if they need a more highly effective or higher potency treatment.
Okay, a person writes that, well, let's ask for it differently. Okay, a person at 65 diagnosed with SPMS and has active progression, would you recommend going on to any specific treatment?
You know, we do have ones that we consider. I wouldn't want to dictate one specific treatment at this point, but it certainly does narrow our choices.
Okay, what are the choices?
You know, I'll go back to what I said initially, is that, we've got lots of choices out there and you have to tailor them individually. I don't want to be in a situation of somebody feeling that everybody's got to rush toward one therapy and that only one therapy is going to be helpful. We got to take, it's complicated, and that's one of the variables you look at. But we do have, for example, I probably would not use an interferon in a situation like that.
Next, would you recommend stopping a disease-modifying therapy at any specific age?
That's a really good question, and I can tell you you'll find a lot of good expert MS neurologists who may disagree about that. I would say we are treating MS longer than we used to. Is there a point where we may stop treatment? Yes, probably so, and there are different strategies perhaps for doing that, but where that occurs is going to depend, again, on an individual situation. So you start asking the question, somebody probably in their 60s and 70s, but whether you do it or not kind of depends on the individual situation, the preferences and comfort level of the person, and the therapies that are available. As I mentioned, we've got lots of good therapies available right now. We're going to get even more available in the next few years, and so it's going to depend on those therapies that are available also, and how effective they may be in progressive disease. Because the development of new drugs, even though they're going to be looked at with respect to ability to suppress relapses, we're going to be looking very hard at their ability to prevent progression as best we can. The problem is, in knowing whether a drug is effective for progression, it's going to take years. You can't do it in a 2-year trial, which is essentially the most practical and cost-effective way of assessing new drugs. So it's very hard to tell whether a new drug on the market is going to be that helpful for progressive disease, because it just takes so long to study. So we depend on what's called real-world experience. So we continue to monitor and look at how people are doing, but that's not the same as what the FDA looks like. And so we're limited in what we can talk about, and certainly what the drug companies can talk about, if it's not on the FDA label in America. But progression specifically may not be adequately addressed in just a 2-year study, and the 5 and 10-year studies that the FDA would approve are just not going to be done.
Okay, thank you. I only have time for 2 more questions. The first one is if somebody has extreme fatigue, can this lead to any other chronic conditions such as insomnia?
I would say it's probably the other way around. Insomnia
I would say that too,
significant
right?
Fatigue.
Okay, next question. What are treatments that are available for chronic insomnia with no other condition is present? Medication, CBT, sleep hygiene practices fail, and can MS fatigue lead to, to chronic insomnia again? So
I'd say no.
asked and answered. Gotcha.
Yes, that's the other way around.
All right. If a patient has progressed from relapse remitting to secondary progressive, would there be any reason for a doctor to not disclose this as a new diagnosis regarding insurance purposes or et cetera?
I think that people who work in MS can be divided. There are people who are lumpers and people who are splitters. I happen to be a lumper. I think MS is the same disease. It just has different manifestations over periods of time. There are other people who've been splitters historically in the last 10 years that kind of happened, and all of a sudden we were dealing with relapsing remitting, and relapsing progressive, secondary progressive, primary progressive. It leads to the impression these are different diseases and need different treatments, and I'm not so sure that's the case. I think MS at different times in an individual, may warrant different treatment, but I think personally that they're all part of the same disease. So I wouldn't say, oh, now you have secondary progressive MS, for example. I'd just say your MS is progressing.
Thank you. Last question before we go on to our final speaker of the night. Okay, and the question that I have from online is, what can you tell us about statins?
Statins and MS?
Yes.
I just say, statins are part of good cardiovascular health, and people with MS, as much or more than anybody else, need to have good cardiovascular health.
There are certain doctors that have stated things about using statins in the past.
Yeah, that really hasn't borne out as being a specific treatment for MS. So I wouldn't want to take a statin and say rely on that to the exclusion of the known MS treatments. And nor would I want to encourage people to have the expectation if they took that was going to really help their MS. I think we don't want people with MS to have a stroke because they're probably may well do more poorly. They may be more at risk. So I would say statins and other medications that help prevent people from having strokes and hardening the arteries and such are very important in people with MS.
Great. Thank you very, very much. Thank you for everything.
Thank you.
Round of applause. Thank you. Have a great day.